Pudukkottai Budan, a weekly academic program of ASA Pudukkottai. We will start with welcome address by our Secretary Dr. M. Periyaswamy. Over to Dr. M. Periyaswamy, please.
Thank you, sir. Good evening to all. I am Dr. Periyaswamy, Secretary, Indian Society of Volunteers, Pudukkottai branch. Welcome you all this 12th Pudukkottai Budan event. On behalf of ISA Pudukkottai, the city branch from Tamil Nadu, I am very glad to invite and welcome you all in this 12th online CME program for PGs and anesthesiologists. Conducting on every Wednesday evening 6 p.m. I want to tell you the real picture of this event. It is my duty to thank our academic chairman, Dr. A.L. Meenakshi sir, for this successful event. And he is the real backbone of this event. First, I welcome you, sir. I welcome sir for this Pudukkottai Budan 12th online academic CAB program. Next, I welcome our President Dr. A.L. Dr. Suresh Kumar and Treasurer Dr. David, my city branch members, delegates for this event. And today we are having Dr. Thomas Koshi as a chairperson, is Professor of Cardiac Anesthesiology, Sri Tirtharal Institute of Medical Science, Trivandrum, Kerala. I welcome you, sir. I welcome you and I invite you for this event, sir, for being here with us today as a chairperson.
Thank you.
Next, I welcome Dr. Poonam Godke, a consultant anesthesiologist, Dvt Prophylaxis Hospital and Research Center, Pune. Madam is going to talk about anesthesiologist and anticoagulant, or in other way, anticoagulant and anesthesiologist. Madam, I welcome you, madam. Next, I welcome Dr. Maniska Katitkar, Associate Professor, Ashwini Medical College, Solapur. Madam is going to talk about anesthetic management of emergency surgical patients with deranged coagulation profile. Madam, we welcome you, madam, on behalf of ISA Pudukkottai. Next, I welcome Dr. Dayananda Murugesan, a resident from Deenadayan Mangeshkar Hospital and Research Center, Pune. Sir is going to talk about coagulation cascade. I welcome you, sir. Next, I welcome all the delegates and from various parts of the country. Regarding our association activities, this is created by Tamil Nadu Medical Council. So if you want to have credit hours, you note it down. These are the details for applying credit hours through our ISA Pudukkottai account. Bank account details are there. This is a ISA account number, Annavasal 3856859628. This is account number. And you have to send the details to the ISA Pudukkottai at yahoo.com. And today we are having topic on coagulation and its disorders. We are having speaker from the famous and world record singer, Dr. Lata Mangeshkar, completed college, and they are going to talk about coagulation and its disorders. So, small note about that: coagulation is a teamwork of 13 factors. They are assembled and act according to their order. Coagulation is intrinsic and extrinsic are in either way. It's intended to stop the blood loss. Coagulation in vivo are always harmful in every vessels. In vitro are meaningful to save the soul. Blood is a liquid organ run between solidarity and fluidity. Blood is a liquid organ run between solidarity and fluidity. Better we can understand the coagulation and its cascade. With this, I once again thank you all for attending this event. And I once again thank on behalf of ISA Pudukkottai. Thank you for the opportunity, sir. Thank you, sir.
Thank you, Dr. Periyaswamy. Respected our academic chairman, Dr. Alam, sir. Dear Treasurer David, today's chairperson, Dr. Thomas Koshi, sir. Today's speakers, Dr. Manisha Katikar from Solapur, Dr. Poonam Kautki from Pune, and Dr. Dayanand Murugesan from Pune. Dear attendees, delegates, PGs, and practicing anesthesiologists, once again I welcome on behalf of our ISA Pudukkottai branch, a tiny branch in the national map of India. But in spite of that, we are able to conduct for the past 3 months consistently, persistently academic activity, which involved a lot of speakers all over from India, variety of topics, which is immensely useful for all the practicing anesthesiologists to refresh and review their knowledge. And very, very guideful and useful for postgraduates in particular. The topics chosen are most of them are exam-oriented topics, and they can easily follow it for their examinations and viva, etc. At the outset, our branch was very indebted to our academic chairman because he is the guiding force who made us possible. The topic today is of very interesting, and so many advances have come in the future and in the days we are practicing. And I expect and our speakers will fulfill the criteria and enlighten our knowledge. I make it a point everybody should join with their names, not with their mobile or some other names, so that it will be useful for the credit hour counting. Once again, I welcome you all, and I request all the attendees to post your questions in the chat box so that the discussions in the later session will be very useful for us. I hand over the proceedings to our academic chairman, Dr. Alam, sir. To Dr. Alam. Thank you.
Thanks, Mr. President. Respected President, Secretary, Treasurer, and members of Pudukkottai City Branch. Today, I'm immensely happy that we have come to the 12th edition for this successive weekly webinar. And this time, we are having a discussion on anticoagulants. And we are happy to have the 3 faculties from Maharashtra. First will be Dr. Manisha Katikar. Dr. Manisha Katikar is in the conference scene from 2000. I remember that year 2000 because I was also there since the year 2000. So for the 22 years consecutively, Madam is participating in conference lectures and CME lectures. She is basically a neuroanesthesiologist. Her husband is a neurosurgeon, and madam was already delivered a lecture in Pudukkottai webinar, that is Tamil Nadu state webinar organized by Pudukkottai city branch. Madam is such a kind-hearted lady who used to take care of her mother-in-law. So that is a big thing. For the 22 years I am seeing her, she is active, ever smiling and affectionate as usual. And she was the governing council member of Maharashtra State ISA, then editor, then secretary, then vice president, now president of the Maharashtra State, which is having the largest number of members. And in the national scene, she is the associate editor of IJA. She is the coordinator for ISA Cultural Club. Madam is a good dancer also. She is having so much of extracurricular activities, and she has won so many awards, mainly the Rukmini Pandit Award and COLS Award. So Madam is a heroine of Maharashtra State, and she is running a lady WhatsApp group, which is popular, and she has many members in that. So I welcome Madam on my personal capacity and in the friendly capacity. So next comes the Dr. Poonam Godke. Madam was ex-professor, that is for 7 years. She was a professor, and now she is a consultant in Dinanath Mangeshkar Hospital, and she has won so many awards, and she has multiple national and international publications to her credit. So just like Manisha Madam, she is also having a lot of publications. And the postgraduate, interestingly, she is participating in a Maharashtra team. But Dr. Dayanandan is basically from Madurai, and he is doing his DIP&B in Dinanath Mangeshkar Hospital, and he is a fresher. He has joined only 2 months back, and he is going to deliver a lecture which is going to be eye-opener, because coagulation cascade is very difficult to recollect and remember. It is a very tricky area. So all these 3 faculties will throw much light on that. And as usual, we had a problem to cap up all these. We need a good chairperson who can command the entire faculty, and we could locate very easily Dr. Thomas Koshi, because day in and out he is dealing with anticoagulants. He is a professor of cardiac anesthesiology in the prestigious Institute of Sri Chitra Tirunal Trivandrum. So even patients will be longing for Sri Chitra, and even they have devised their own valves, Chitra valves. And when anesthetists, they will see it as a dream to enter into the Chitra Tirunal Hospital. And Sir is a HOD of that cardiac unit. So he is the apt person, and he is known everywhere. He is known everywhere throughout the country. He is very soft-spoken. He is very soft-spoken, and he is up to the point. Whenever he talks in the conference, I have seen him, he will be up to the point. His lecture will be full of content, because his brain is full of content. And as he is dealing with the cardiac anesthesia, even he is very sympathetic to the postgraduates and the colleagues. He used to guide me whenever I have doubts in that cardiac anesthesiology. So he is always friendly, and he will help everyone always and in all ways. That is his credit. So we request Dr. Thomas Koshi sir to take active part in that, and we really privileged to receive all these 4 faculty, and we are happy that we are on time. We are on time every time. Every week we are preparing, starting it on time, and that shows. Even now itself, 70 people have entered. So we used to deliver the scientific podium to the chairperson before 6:20, and now I am handing over the session and the scientific podium to Dr. Thomas Koshi sir. Please, sir.
Thank you, Dr. Meenakshi Sundaram for inviting me to this academic program, which has been running successfully for past 3 months. And it was very heartening to know that this is the 12th episode. So let me start with my sincere thanks and appreciation to ISA office bearers of Pudukkottai, President Suresh Kumar, Secretary Periyaswamy, and Treasurer David. And also happy to know that you got credit hours from the Medical Council of India. And regarding the topic, the Secretary and the President highlighted that this is important for patient management as well as for the exam. So personally, I start with the sentence that bleeding patient is management is easily can be answered in the theory part, but very practically difficult in the OT, especially when there is a coagulation problem. So we are going to listen to 3 lectures and different aspects of this coagulation. And first lecture is on coagulation cascade, and the second lecture is on anticoagulants, and third is the practical management of emergency surgical patient with deranged coagulation profile. So we have 2 speakers from the Mangasha Hospital, Dr. Dayanandan and Dr. Godke. I have got 2 friends in cardiac anesthesia there, Vinayak Dasulkar and Dr. Nilesh Duwarkar. Are they there?
Yes,
So
sir.
they are in cardiac
They are
anesthesia.
very much there. Yes, sir.
Yeah. So they are my. So Vinayak and me did PDCC together in Fujitra in 1993, and Nilesh was my student later on. So the first speaker and the second speaker are very happy to know that from Dinamnath Mangash Hospital. This hospital runs DNB as well as FIACTA of fellowship program of FIACTA. So straight away we'll start. I think the time given for 3 of you is 70 minutes, so roughly around 20 minutes for each speaker. And first speaker is Dr. Dayanandan Murugesan. So it was already mentioned here that he is a first year PG DNB, and he is going to talk on coagulation cascade. So I invite Dayanandan to load your presentation. And
yes.
Meenakshi Sundaram, how is the discussion? Is at the end of the 3 lectures or
Yeah,
after
it
each
is at the end of the 3 lectures, so that it will be comprehensive. It is at the end only.
All right. Okay. Okay. So those who are listening, please put your questions in the chat box. We'll try to address each and every question from the speakers as well as the faculty sitting here. Thank you. Please, Jayanandan, there, can you start now?
Yes, sir. Yes, sir.
Okay.
Sure.
All right. Yeah. Okay.
Can I start now?
Yes, yes, please.
Yes. First of all, good evening, and thanks for the opportunity, and thanks to ISA Pudukkottai for organizing this amazing academic program. And I'll start with a quick physiology overview of coagulation system. Coagulation is a dynamic system, and the understanding of blood coagulation system has evolved in recent years in our anesthetic practice. Normal coagulation pathway strikes a balance between procoagulant pathway, which is responsible for clot formation, and the mechanism which inhibit the same at the different sites other than the vascular injury. Imbalance of this coagulation system may occur during surgery, perioperative procedures, and critical care. That's why it's mandatory for perioperative physicians to have a proper understanding of coagulation physiology. The coagulation pathway involves three main elements, which is the endothelium, second one is platelet, and the main thing is coagulation cascade. The endothelium lining the vascular wall exhibit antithrombotic properties due to factors like glycosaminoglycans like heparin sulfate and fibrinolysis activators. When a vascular insult occurs, the first thing to occur is arteriolar vasoconstriction, which is mediated by neurogenic response and local mediators like thrombus A2. Then it proceeds with primary platelet plug. Platelet plays a major role in forming the primary plug. What happens is when there is an insult, subendothelium is exposed. Subendothelium contains von Willebrand factor, which acts as a receptor for platelets. The platelets, which has glycoprotein 1A, sits with
வேற அவங்க ஆர்டர் போட்டுருக்காங்க கவிதாட்ட கொடுத்துருங்கன்னு டீடைலா சொல்லிட்டு போயிருக்காங்க. நான் என்ன எனக்கு யாரோட போட்டு அனுப்ப போறேன்? நானு
ஹலோ
ராஜம்னு இருக்கான பேரு எனக்கு தெரிஞ்சு யாருமே இல்ல. ராஜம்
Somebody has keep the mic.
ஒருவேளை ஓனர் அம்மா கவிதாவா இருக்குமோ?
ஆமா. Please keep your audio off, microphone off. There's a lot of disturbance coming. Okay, then we can continue.
Yes. Okay. After vascular injury, von Willebrand factor is expressed. It acts as a bridge between platelet and endothelial collagen. This is where the platelet adhesion occurs. Once adhesion occurs, there is degranulation and further adhesion of platelet occurs, and it leads to activation. And this forms the primary platelet plug. Primary platelet plug can arrest bleeding temporarily. Am I audible?
Yes, you are audible.
Yes. Then the process of secondary hemostasis starts. I said that after the vascular insult, subendothelium gets exposed. Not only von Willebrand factor, the other factors of coagulation gets exposed to. The main factor to gets exposed is tissue factor, from where the original pathway starts, which I'll be discussing later. Coagulation cascade is a series of enzymatic reaction where a proenzyme is proteolized into an enzyme which catalyzes the next step of the reaction, and the cascade continues. We have 13 main factors which involves in the coagulation pathway. So this is the classical pathway which we have studied in earlier years. Traditionally, it contains two pathways, extrinsic and intrinsic, which combines together the common pathway. The extrinsic pathway is the main pathway which occurs in vivo. It is activated by the tissue factor which gets expressed after a vascular insult at subendothelial tissue. The tissue factor, on combination with factor 7, which is stable factor, proceeds with the extrinsic pathway, and it leads to the activation of factor 10. When it leads to activation of factor 10, 10A is getting produced, and the 10A activates the prothrombin, and thrombin is formed. This is the rate limiting step in the coagulation pathway, where 10A is converted into 10A. Calcium and phospholipid are a major cofactor which facilitates this reaction. When once thrombin is formed, it leads to formation of it helps in the enzymatic reaction of conversion of fibrinogen into fibrin, and fibrin cross-linking occurs. This is a temporary clot, unstable clot, and this has to be converted into stable clot, where the factor 13 comes into action. Factor 13 facilitates the conversion of unstable to stable clot, and finally the clot is formed and hemostasis achieved. Intrinsic pathway per se is not a parallel pathway, as we have studied earlier. Recent studies have shown that intrinsic pathway augments the further production of thrombin, because the thrombin which is formed during the extrinsic and common pathway is not robust to form profibrinogen to fibrin. So what happens is there is a positive feedback mechanism through intrinsic pathway, where the thrombin activates the factors which are involved in intrinsic pathway, that is factor 12, 11, 9, and 8. The positive loop continues and produces more thrombin, and the common pathway proceeds to form this stable clot. Once the bleeding is controlled, counter-regulatory mechanism like tissue type plasminogen activator starts its action and limits the clot formation to the site of injury. I'll give a brief overview of the test for coagulation. While we do workup for the patient, we usually start with platelet count, bleeding time, clotting time. Bleeding time is for the test of platelet phase, and clotting time, PT and APTT are for coagulation cascade. Prothrombin time, it screens for the activity of proteins in the extrinsic pathway. Factor 7 is a vitamin K dependent coagulation factor, so PT can be used to guide treatment of patients with vitamin K antagonists. APTT, it screens for the activity of proteins in the intrinsic pathway. The PTT is sensitive to anticoagulants effects of heparin, therefore it is used to monitor its efficacy. Thank you for this opportunity, and hope Godki madam will continue with the next set of presentation. Thank you.
Thank you, Dayanandan. You concise the coagulation cascade and just mentioned the tests to assess the coagulation cascade. And you also mentioned that there is an injury starts with the platelet aggregation followed by a clot, and also the mechanism by which the clot is not extending to the entire flow further in the vascularity. So there are mechanism for preventing bleeding. There is also a mechanism in the human body to prevent further clotting. So everything is in a balance. And you also mentioned about the test of coagulation. So prothrombin time is to measure the extrinsic and the common pathway, and APTT is for measuring the integrity of the intrinsic mechanism and the common pathway. So now we go to, thank you for that illustrative lecture. Now we go to Dr. Poonam Kodki. So she's a consultant in the same hospital, and she's going to talk about the anticoagulants and the anesthesiologist.
Is the slide visible whole screen?
Yes.
Yeah. Good evening, everyone. At the outset, I would like to thank the Pudukkottai branch for inviting me here for the academic activity. I bring greetings from Dinanath Mangeshkar Hospital and Research Center, Pune. And my topic of presentation is anticoagulants and anesthesiologists. So don't be astonished by this slide of the end. But this is what generally happens when we encounter a patient who is on anticoagulants. All we can think about is whether I can give spinal to this patient. What about the heparin? What about the catheter in situ? So we just restrict ourselves to anticoagulants and central neuraxial block. But that is not it. When a patient comes to us who is on long-term anticoagulants, there is an inherent risk of thrombosis versus a risk of bleeding, which we have to take into consideration. And then we have to formulate an individualized plan. So we have to basically strike a balance between the bleeding risk and the thrombosis risk. Now, although Dr. Dayanand has very excellently spoken about the coagulation cascade, this is what happens despite of learning the coagulation cascade so many times, we forget the basics. But for my session, I would request you to just remember two main things. First is the factor 10A, which is the rate limiting step. And the second is the prothrombin or the thrombin factor 2. So let us start with a case. This is a patient who is 68 years old female, known case of rheumatic heart disease with mitral valve replacement done 11 years ago. She sustained a fall with fracture neck of femur and now is posted for hip hemiarthroplasty. She is on tablet warfarin 2 milligrams OD, also on antihypertensives and oral hypoglycemic agents. ECG is showing atrial fibrillation with controlled ventricular rate. and 2D echo is acceptable. So through this case, I want to highlight my objectives for the talk. Firstly, we will have a brief overview of anticoagulants, then the perioperative management, whether to interrupt or not to interrupt the anticoagulants. And of course, we are going to talk on the regional anesthesia and anticoagulants. Not more than a decade ago, we used to look at each other and talk. And this was the time when we were supposed to know only two anticoagulants, heparin and warfarin. But as days have passed by, we now text rather than talk. And with the advances in science, we have many more anticoagulants added, which keep on adding daily that we have to know. So we are not going to talk in detail about these anticoagulants. Now, when one has to classify the drugs that act on the coagulation system, we can broadly classify them as antiplatelets, anticoagulants, thrombolytics, and also the herbal supplements. Now, our focus today is on the anticoagulants. Now, this is a classification of direct, indirect, which I do not like much. I would like to simplify the classification like this, parenteral and oral. So it is like heparin versus warfarin. In the parenteral, we have our heparin, which could be unfractionated, or the low molecular weight heparin, which acts on the factor 10A. And in the oral, we have factor 10A inhibitors, thrombin inhibitors. So these are called as the direct oral acting anticoagulants. And then, of course, we have the vitamin K antagonist, that is the warfarin. We are not going to discuss the pharmacokinetics, dynamics in detail, but only points pertinent to us and anesthetists is what we are going to look. So heparin, as we all know, is unfractionated and low molecular weight heparin. If we have to compare these two, unfractionated is the one which can be given subcutaneously. It has a rapid onset of action. Its anticoagulation effect can be easily monitored, and it is acceptable in renal failure. However, the complication of this kind of heparin is that it can induce thrombocytopenia. Coming to low molecular weight heparin, that is enoxaparin or dalteparin, it has a longer duration of action, can be administered subcutaneously only, and lab monitoring is not generally necessary. It is, however, relatively contraindicated in patients with renal failure. And if at all you have to monitor, you have to know the anti-factor 10A level assay. The advantage is that it does not lead to heparin-induced thrombocytopenia as much as the unfractionated one does. Unfractionated one can be reversed with protamine, but low molecular weight heparin is less likely to be reversed with protamine. Coming to warfarin, now when we say that this is an indirect acting oral anticoagulant, what does that mean? It means that it does not inhibit the production of any anticoagulant per se. It rather inhibits the epoxide reductase, which is involved in the formation of vitamin K dependent factors. That is why it takes a longer time to act as compared to the other oral anticoagulants. There are many problems with warfarin. Firstly, the bleeding risk is very high. Intracranial hemorrhage can occur. It is majoritarily bound to the proteins. It has many interactions with food and drugs. Frequent monitoring is required. Despite of all these pitfalls, warfarin is still a very popular oral anticoagulant. If you have to look into the indications of these two anticoagulants, primarily the patients, those who come to us would be suffering from atrial fibrillation, those who are having mechanical heart valves, venous thromboembolism, also patients with peripheral bypass, lung embolism, and mainly these could be combined with antiplatelets in the form of triple therapy. Coming to direct orally acting anticoagulants, they were also called as novel oral anticoagulants, but as many drugs came into this class, there was no novelty left. And so now it is also called as non-vitamin K oral anticoagulants. Now here we have drugs which act or inhibit factor 2A, that is thrombin, and factor 10A. Dabigatran is the drug that belongs to factor 10A inhibitor. And the rest of the drugs, the mechanism of action is in the name itself, like rivaroxaban, apixaban, edoxaban. So axaban, that is XA-ban or factor 10A inhibitor. Now here, what is important about dabigatran is that it is 85% metabolized by the kidneys. And therefore, creatinine clearance measurement is very, very important, which has to be taken into consideration when a patient is on dabigatran. So what are the indications for these new oral anticoagulants? So basically, they can be given as a thromboprophylaxis for patients who are undergoing elective hip or knee surgeries. Stroke prevention for patients with atrial fibrillation. Now, these drugs are studied only in non-valvular atrial fibrillations. They are not recommended because partly they are not studied in valvular atrial fibrillation. Rivaroxaban, in addition, can also be used as a treatment for DVT and pulmonary embolism, and also a prevention of recurrent DVT and PE in adults. So let us come back to case 1. How do we manage this case? Now, before we think of planning anesthesia for these patients, like I mentioned earlier, we have to strike a balance between the thrombosis risk and the bleeding risk. It is easier said than done because there are so many factors, few interdependent, few dependent, independent factors in each of these risks. And therefore, I pose these 4 questions which we need to ask ourselves before we decide upon the anticoagulants. So first would be the indication why the patient is on anticoagulants. Secondly, should the anticoagulants be continued? So to answer this, you need to know the bleeding risk. What will happen if we continue the anticoagulants? How much would the patient bleed? So that can be a surgical bleeding risk or the patient's inherent risk for bleeding. So that you have to answer. Secondly, can it be stopped? Now for this, you need to answer the thrombotic risk. What would be the thrombotic risk after discontinuation of the drugs? And if at all you have to stop it, will bridging be required? So these are the main questions you need to answer so that you can balance out the thrombosis versus the bleeding risk. So like I mentioned, the bleeding risk could be either surgical bleeding risk or patient's bleeding risk. Now, initially, this was classified as low risk, medium risk, and high risk. Now, however, the classification is low risk and high risk and moderate risk as together. So low risk surgeries for bleeding, that is, minor dermatomal surgeries, skin surgeries, cataract, glaucoma, dental procedures, interestingly, lap cholecystectomy, biopsy of a compressible site, or giant aspiration. Moderate to high risk would be all kind of vascular surgeries, neurosurgeries, spinal or epidural surgical procedures, urological procedures, breast surgeries, thoracic surgeries, pacemakers, liver biopsies. So when the patient comes to you, you classify his surgery as whether it is a low risk of bleeding or high to moderate risk. Then how do we gauge the patient's bleeding risk? For this, we need to know the Has-Bled score. What is this Has-Bled score? You score the patient according to these parameters and give points. Hypertension, abnormal liver or renal function, which has 1 or 2 marks, stroke, bleeding, labile INR, elderly patients whose age is more than 65, drugs or alcohol. So maximum score would be 9. Now the patients who come to us generally are hypertensive, elderly, on drugs, or may not have a liver or renal dysfunction. So on an average, 3 to 4 is the score that we get in our patients. Thrombotic risk. So basically, we are talking about the DVT and the pulmonary thromboembolism risk. So to gauge this risk, you need to know the CHADS-VAS score. So it is CCF, hypertension, age more than 75 years has 2 points, and age between 65 and 74 years is 1 point. Then history of stroke, TIA, and thromboembolism, 2 marks, vascular disease, diabetes, and female patients. So more commonly, our patients would be hypertensive, elderly, diabetes is endemic in India, and if there is a female patient, naturally the score becomes more than 3. So you have to compare the CHADS-VAS score to the Has-Bled score. Remember, even if the CHADS-VAS score is 0, there is still 0.2% risk for thromboembolism. And a score more than 3 of Has-Bled means that the patient's risk is high for bleeding. So you compare these 2 scores. So what about our patient? In our patient, what is the indication? It is the prosthetic valve. So remember, prosthetic mitral valve of any type carries a very high risk of thromboembolism. Aortic valve prosthesis, especially the bileaflets one, are considered to be low risk. So our patient is having a prosthetic mitral valve. So that gives him a high risk of thromboembolism. Should it be continued? So what is the surgical bleeding risk? Fracture neck of femur. It is a high surgical bleeding risk. And if you calculate the Has-Bled score, it comes to around 3. Should it be stopped? What is the CHADS score? It is around 4. So certainly the risk of thrombosis is more than that of bleeding, but the bleeding risk, if you combine the high surgical and Has-Bled, is definitely high. So whether to stop or not to stop. So here the solution is you will have to stop to prevent the bleeding, but then you will have to bridge these patients. So now we come to the concept of bridging. So how is bridging done? When the patient is warfarin, you have to stop warfarin for 5 days before surgery. Now, in the past, bridging was very common, but now it is not no more followed, and there is a shift to otherwise not bridging these patients. Currently, bridging is advisable to patients only who are high risk. So what do high risk patients mean? Those patients who are having atrial fibrillation, those patients who have prosthetic valves, and in those patients who have a thromboembolism within past 3 months. They are the patients in whom bridging should be considered. So in bridging, you stop the warfarin, use therapeutic doses of either low molecular weight heparin or unfractionated heparin IV, and then administer the doses 24 hours before if it is low molecular weight, if unfractionated, 4 to 6 hours. And then you can resume these drugs back post-surgery after say 48 to 72 hours once hemostasis is confirmed. So this is how bridging would be done in our patient, but waiting for 5 days in our patient may not be possible because it is a fracture. If the same patient is for abdominal malignancy, however, it is a highly elective procedure and you can stop for 5 days. You can adjust the last dose of heparin and you can probably give a GA with epidural anesthesia for the patient if the surgery is abdominal malignancy. Rest all would stay the same. Now, case 2 is exactly the same patient, but she's posted for cataract or for that matter, endoscopy or dental procedure. So again, the questions would remain the same. The answers would now differ, especially should it be continued. Now here, it is a low surgical bleeding risk, cataract. So now the thrombosis risk is very, very high than the bleeding risk. So you would not stop the anticoagulants and continue the anticoagulants throughout the surgery. Case 3 is a 65 years old male who is diabetic, hypertensive, post-COVID and put on DOAC for prevention of venous thromboembolism, who is now posted for nephrolithotomy. There is no other positive history. Now in the post-COVID period or in the post-pandemic period, if I take the privilege of calling the pandemic over, we see so many patients who are put upon the DOAC drugs. So how do we manage these drugs? Now here comes the concept of thromboembolism. We fear the thromboembolism in such patients. Now there are many risk factors for the venous thrombus formation, but I would like to highlight those factors in which we commonly encounter in our patients. So surgery, like the abdominal, pelvic, or orthopedic surgeries. In these surgeries, the Furcos triad come into picture and the patient becomes more prone for thrombus formation. Trauma, burns, paralysis. Now we all know that general anesthesia leads to more chances of DVT as compared to the central neuraxial black. So any paralysis, even for 30 minutes, risks the patient for thrombus formation. Malignancy, pregnancy, or even the postpartum period, myocardial infarction, CCF, stroke, obesity. History of venous thromboembolism, very, very important. Oral contraceptive use, chemotherapeutic agents, increasing age, and smoking. So when patients has one or multiple of these factors, the risk of venous thromboembolism increases many, many fold. So let us answer the questions. Indication, prevention of venous thromboembolism, so which is a low risk. Should the anticoagulants be continued? Now it is a nephrolithotomy, so it is a high surgical bleeding risk. If you calculate the Hasbled score, it would be 4. Should it be stopped? So the CHAD score is less than 3. So here, the bleeding risk is more than the thrombosis risk. And so you need to stop the direct acting oral anticoagulants. Direct acting oral anticoagulants have not been recommended to bridge. So you need not bridge it with heparin, but the timing of discontinuation of DOAC is very, very important and differs for individual agents. So here the main factor of creatinine clearance comes into picture. And if you see regarding the dabigatran, the creatinine clearance has to be really very optimum for you to discontinue it at least for 48 hours. So on an average, you should not touch these patients within 36 hours approximately after the last dose has been given. And even if you give spinal or a central neuraxial block, the timing after the catheter removal for the next dose is considered to be 6 hours if it is an atraumatic puncture. All right, if it is a traumatic puncture, 24 hours have to be passed. So you have to look into the kidney profile. You have to calculate the creatinine clearance so that you can stop the drugs wisely. Now, case 4 is a 50 years old male who is diabetic, hypertensive, well controlled, and is posted for knee arthroplasty. Clinically and lab-wise, he's okay. Now, you plan to do this case under spinal anesthesia and probably a ductal canal block for post-operative analgesia. Now, Dvt prophylaxis is something that we all follow, and it is highly recommended for patients who are undergoing knee arthroplasty to undertake a Dvt prophylaxis. One thing that we forget is, although anticoagulant is the topmost prophylaxis for DVT, it has to be combined with other mechanical measures to prevent deep venous thrombosis. So when we talk of deep venous thrombosis, prophylaxis, and the central neuroaxial block, there are so many guidelines that come into picture from various society. Now, this is the recent guideline from the European Society of Regional Anesthesia. So as per these guidelines, you can give any of the anticoagulants for DVT prophylaxis in knee arthroplasty. It could be Warfarin, dabigatran, or any other oral anticoagulants, low molecular weight heparin, or fondaparinux. So nothing has been changed over what we know already. So dabigatran, as I mentioned earlier, has to be at least stopped 48 hours if you're giving a low dose, and if it is a high dose, 72 hours. No testing as such is required. If you're giving low molecular weight heparin, now this is what we follow in our institute. We give post-operatively on the same day Clexane is given OD for 3 days. And then it is combined with the compression stockings. And at discharge, we convert the low molecular weight heparin into rivaroxaban, which is continued for another 1 month at least. So when you give low molecular weight heparin, low dose, 12 hours or 24 hours if the creatinine clearance is really low. Now, when the catheter is in C2, you should not give any vitamin K antagonist. You should not give any direct orally acting anticoagulant. You should not give high doses of low molecular weight heparin or unfractionated heparin. This is very, very important. Now, we always have a threat about, now this is a picture sent by my friend, wherein they had a spinal hematoma because they had administered anticoagulants when the catheter was in C2. So we should not only worry about the spinal hematoma, but there are other blocks also which we need to cater for. Now, these are the deep nerve blocks, and they carry equal risk as the uraxial. I thought it wise to discuss with you and to tell you that these are the blocks which also need to be given with caution if the patient is on anticoagulants. Stellate ganglion block, deep cervical plexus, cervical paravertebral. In the upper limb, you have the infraclavicular block, which is at risk. Obviously, the central neuraxial blocks, lumbar plexus, psoas compartment, lumbar sympathectomy, lumbar paravertebral, the QLB fascia transversalis block, even the PENG block should be given with caution. And of course, the sciatic, spinal, and epidural. So in the ESTA guidelines, they mentioned that you may give these blocks with ultrasound guided techniques if those are given by experts. So I hope that by the end of this talk now, you at least can make a decision between the venous thromboembolism risk versus the bleeding risk and have an optimum plan for your patient. So to summarize, review the anticoagulant that the patient is on in detail, assess the clinical status and stratify the risk. And a joint decision has to be made regarding the interruption of the anticoagulant. You should discuss with the orthopedic surgeon and at times with the hematologist. Assess the need of bridging for these patients. And do not forget to follow up these patients in the post-operative period. Thank you so much for your patient hearing. And I once again thank the Pudukkottai branch for having me here today. Thank you.
Thank you, Poonam, for that illustrative lecture with a practical application and the brilliant examples with cases.
Thank you, sir.
That shows actually the practice to be followed in every case, weighing the thrombotic risk with the bleeding risk. And we have got guidelines as we have illustrated and the scoring systems, and which has to be used in every case. So it's a very, very interesting lecture, and I enjoyed listening to the lecture.
Thank you so much, sir.
Because because I am not dealing with this non-cardiac surgery, so we only give heparin and the reverse is Potamin. So I hardly give this epidural, thoracic epidural once in 5 months and spinal once in 2 years. So we don't come across. So these are all very important and medical legal implications. So we'll have this discussion at the end. Now, finally, we go to the third lecture by Dr. Monisha. She's Associate Professor in Ashini Medical College Hospital, Solapur. She's going to talk on anesthetic management of emergency surgical patient with a deranged coagulation profile. And this is extremely going to be a risky management inside the theater. Theoretically, it's a very scary proposition when you get the patient inside the theater with a deranged coagulation. And both the surgeons and anesthetists on their toes to manage this patient. Over to Madam, please.
Thank you so much, sir. Respected Chairperson, Dr. Thomas Koshi, sir. Respected President, ISA Pudukkottai branch, Dr. R. Suresh Kumar, sir. Secretary, Dr. M. Swamy, Treasurer, Dr. Y. David, and respected Dr. Meenakshi Sundaram, sir, Academic Chairperson for the ISA Pudukkottai branch. First, at the outset, I would like to are you able to see my slides? Hello?
Slide is not
No,
seen.
ma'am, your slides are not seen. Yeah, because I was also not able to see. I'll just again share the screen. Can you see now?
Yes.
Yes, ma'am. Slide share, please. Yeah. At the outset, I would like to thank the organizers of this academic event, and thank you very much for inviting me here on the prestigious dais of Pudukkottai ISA City branch. My job has been made easy by both our PG students as well as Madam Poonam. I'm so sorry, I'm going to be very sorry as there might be some repetition of the slides, but I think it is necessary for the explanation of various surgical procedures or the emergency surgical procedures that we are going to do in a patient now who has a deranged coagulation profile. My job is going to be a little bit different from what Poonam madam has explained because this is an emergency surgery. So we need to proceed with the surgical case in spite of deranged coagulation profile. So let's see few surgical cases which we do routinely and we face deranged coagulation profile and we need to operate these patients with deranged coagulation profile. Let's see how to manage them. So in the case one, it's a young guy who met with a road traffic accident. He was hit on the right side by the truck and sustained blunt trauma to the abdomen. Ultrasound revealed hemoporoteinium and there was a suspected liver injury. He also had orthopedic fracture. He came with hypotension and hemorrhagic shock. So resuscitation was done with crystalloids and colloids. His lab investigations were sent and they revealed thrombocytopenia and deranged coagulation profile with raised INR and FTP. So now the surgical team wants to explore the patient and to find out the cause for hematuria and to stop the bleeding. I'll just explain the case at the moment and then at the end of our discussion, we will discuss the management of all these cases. Second is a 62-year-old male patient who was hospitalized with vomiting and pain in abdomen since last 2 days. He is febrile, having tachycardia, tachypnea with low blood pressure. USG revealed free fluid in the abdomen. The lab profile was suggestive of deranged coagulation profile. The surgical team thinks that he has an perforation and they want to explore the patient as early as possible and they are behind the anesthesia team to make him fit surgically as early as possible so that the cause of sepsis or the septic shock can be managed properly. This case, Poonam madam had discussed recently. She had shown the photograph of a spinal hematoma. This is the case which I had managed. It is a 62-year-old male patient who was brought to the emergency department with acute onset paraplegia. He was a known asthmatic and hypertensive patient. His MRI dorsal spine revealed a big hematoma right from D5 to D12. It was compressing the spinal cord and that has led to acute onset paraplegia. So what was the reason for this acute onset spinal hematoma? He had
anterior wall acute myocardial infarction, was thrombolized somewhere outside. After 4 hours, he developed acute onset paraplegia, and then he was shifted to the tertiary care for further management because of acute onset paraplegia. On lab investigations, we found that he had deranged coagulation profile. His 2D co was suggestive of anterior wall hypokinesia with basic low ejection fraction, and the spinal surgeon now wants to do the emergency spinal cord decompression as early as possible, and for that they want our patient fit and fine as far as the coagulation profile is concerned. And the fourth case is a 70-year-old male who was brought to the emergency department with a very low Glasgow Coma Scale score. He had undergone mitral valve replacement few years back and had stopped antiplatelet agents now. He complained of giddiness for previous 2 days. The cardiologist at some hospital, in a peripheral hospital, suspected that there was a decreased flow across the mitral wall. So he thrombolized the patient. After thrombolysis, he found that the patient has become drowsy and he was referred to a neurosurgical setup because there was a big hematoma on the left side in the temporoparietal region, which has worsened his Glasgow Coma score. So when we are speaking about the deranged coagulation profile, we are dealing with three investigations: PT, EPTT, and the platelet count. So when we get the reports of PT and EPTT, we must be able to differentiate what might be the exact cause for thrombocytopenia. So if the patient has elevated PT with normal EPTT, there may be factor 7 deficiency, vitamin K deficiency. Patient might be taking warfarin, or there might be sepsis or the DIC. If the patient has normal PT but elevated EPTT, then there may be isolated factor deficiency, something specific factor inhibitor like lupus anticoagulant, or patient might be on heparin. And if the patient has elevated PT as well as EPTT, then it indicates multiple factor deficiencies. Patient may be having high levels of heparin or warfarin. Patient may be suffering from liver disease. He may have low fibrinogen count. There may be dilutional coagulopathy, or patient might be suffering from DIC. So as I mentioned, the acquired causes of coagulopathy, trauma, as we saw in the first case, is the most important cause that can lead to coagulopathy, and these patients usually come for emergency surgical intervention. So a patient with massive blood loss who is resuscitated well with fluids, blood transfusion, plasmas, and other factors may have dilutional coagulopathy. Traumatic brain injuries again associated with DIC, and patients who have severe liver disease with vitamin K deficiency can come with deranged coagulation profile. Dr. Poonam has mentioned so well about all these drugs, and I would not go into the details of the drug, but it is always important whenever a patient comes to you with deranged coagulopathy, one must find out the exact cause for the deranged coagulation profile. Optimization of coagulopathy is important, but at the same time, optimization of the underlying illness is vital. Elective surgery, no issues, can be deferred till the cause of coagulopathy is identified and optimized. But if there comes a need of an emergency surgery, we need to treat the coagulopathy. And it is very important to remember that we need to take this patient either to save his life or to save his limb. But then the management of coagulopathy has to be continued intraoperatively. So when you see a patient, the workup that is needed for diagnosis of coagulopathy should be done rapidly. Ask for complete medical history, past surgical history, drug history, family history. Look for ecchymosis and hematomas, petechias, and bleeding from mucous membranes, and take a good consult from all the specialties involved in the management of the patient, like hematologists. Consult for comorbidities, transfusion medicine people, as you are going to need multiple transfusion agents, and discuss the risk not only with the surgeon but with the patient and relatives, because there is a huge risk associated for surgical intervention in a patient who has deranged coagulation profile. At the same time, just remember that whether you have asked for the history of NSAIDs, because it has been mentioned that Even a single dose of NSAIDs might cause platelets dysfunction. So that is also important history that has to be asked for. Dr. Poonam has already mentioned in which patients you should suspect that patient might have deranged coagulation process if they have history of rheumatic heart disease, atrial fibrillation, prosthetic heart valves, TIAs, DVT and pulmonary embolization, especially in patients who are immobilized for a long time, patients with acute coronary syndrome or who are on rivaroxaban, dabigatran, and other newer anticoagulant agents. The laboratory work which we do routinely, platelet count, laboratory tests like PT, APTT, and thrombin time. If the facilities are available for thromboelastography or rotational thromboelastometry, it should be done. This is because the pattern of thromboelastography may give you a clue for the possible cause for deranged coagulation profile. Laboratory tests for fibrinolysis like D-dimer and FDP will also guide you for management of deranged coagulation profile. And now, here comes the role of anesthesiologist who is in charge of for that surgical case. He needs to take good care of the coagulation status of that patient. Why? Why this is important? He should not miss the minor derangements of the coagulation cascade as it may affect the intraoperative course. There may be unexpected blood losses and there may be some difficulty in surgical hemostasis, and this may lead to risk of post-operative bleeding and again re-exploration, which is going to be more risky in the patient who already has deranged coagulation profile. So for emergency surgery, the major focus should be on possible reversal of all the causes. Not going to go into detail. Which interferes with vitamin K metabolism. You know this, Poonam Madam has already explained that patients who have
Madam, there is a problem with your transmission. I can't hear.
Madam, net connectivity is not proper, madam. Manisha, madam. Net connectivity is not good.
There was some disconnection. I will again share the screen.
Yeah, now we can hear you.
Yeah. Can you see me and can you see the slides also?
Yeah, can you go to the previous slide? I think we missed a few slides. Go to the previous slides. Yeah, that's the thing.
Yeah.
Next slide.
Yeah, next slide. Okay.
Yeah.
Yeah. So I'm not going to go into the details of warfarin, but we must know few clinical points that are related to warfarin. Warfarin interferes with vitamin K metabolism, and as I mentioned, for elective surgery, no issues. You can stop it for 5 days to allow INR to decrease below 1.5. But what has to be done for emergency surgery? If the patient who is taking warfarin comes for emergency surgeries, one need to ask in detail about the history of warfarin. When the patient, what is the last day when the patient had taken warfarin? Has he taken the same dose of warfarin on the morning of that particular event? And if yes, if there is a time, ask the patient not to take warfarin if he is able to take orally. You arrange for prothrombin complex concentrates in the dose of 25 to 50 units per kg. 90% of the patients achieve normal INR within 15 minutes. A second dose may be repeated, but there is again a question of availability and risk of thrombosis that is associated with warfarin. If not, If the PCCs are not available, then fresh frozen plasma, which contain vitamin K dependent factors 2, 7, 9, and 10. It can be given in a dose of 15 to 20 ml per kg. There is a risk of high volume load, especially in patients with compromised cardiac function, and fresh frozen plasmas are known to have low concentration of vitamin K dependent factor 9. Vitamin K can be given in a dose of 5 milligram IV, but it takes 24 hours for INR correction with vitamin K. PCCs with normal amount of factor 7 are known as 4-factor PCCs, and the product without factor 7 is the 3-factor PCC. Guidelines recommend PCCs over FFPs because of their more rapid administration and complete INR correction. Dr. Poonam has explained in detail that you need to keep a balance between perioperative goals, the risk of bleeding, as well as the thromboembolism. Your aim should be achieve INR correction as early as possible, optimize the patient as early as possible for surgery, and at the same time, after the end of surgery, start anticoagulants to avoid the risk of thromboembolism. I'm not going to go into the Hasblatt's score because Poonam madam has already described it in detail, but she has also explained that a score of 3 is commonly seen in many of the patients who has deranged coagulation profile. So that has to be kept in mind. A patient who has score more than or equal to 3 indicates high risk of bleeding. So it is always important to calculate the score and to know regarding the risk of bleeding in a patient who has deranged coagulation profile. So now this patient is for emergency surgery. We need to reverse the warfarin. So what has to be done? Give vitamin K. If PCCs are available, then give 4-factor PCCs depending upon the INR. The dose is depending upon the INR values. Check PT-INR at 1 hour, 6 hours, and 24 hours after 4-factor PCC. If INR is low, give fresh frozen plasma. If INR is more than 1.5, give vitamin K. But as far as is considered, at many places, the PCCs are not available. So whenever you get a patient with deranged coagulation profile, one need to give fresh frozen plasmas along with vitamin K, because we need to operate this patient immediately or urgently and get the INR low as early as possible and also stabilize the patient. Is there any role of recombinant factor 7A? Yes, it is an agent for anticoagulation reversal. It is helpful in warfarin-induced intracranial hemorrhage. Earlier action, it has earlier action earlier than PCCs and FFP. However, thrombotic complications as well as cost are the important questions that has to be answered for the use of recombinant factor 7A. The popularity of novel oral anticoagulants, already mentioned by Poonam. Newer anticoagulants are being commonly used in clinical practice. Many of the patients now we are finding are on dabigatran or rivaroxaban, especially the post-COVID era. And most of these agents have no reversal agents. And this is a real life-threatening scenario in a case of, especially in a case of intracranial bleeding, because of there is no reversal agent available against dabigatran. And this can lead to irreversible cerebral herniation. The experience in their use is still limited. There is insufficient evidence related to fewer studies that have been published. There is no reliable lab test to measure their effects. With exception of dabigatran, there is no reversal agents for these medications that are available. And at the same time, no guidelines are available for reversal of dabigatran, especially in neurosurgical patient who comes with who comes with intracranial hemorrhage. So what are the agents that can be used for reversal of dabigatran? Oral activated charcoal. If not, then reversal agent like idrusizumab is also available. You can arrange for 4-factor PCCs if the drug is not available. And in a patient who has compromised renal function, you may consider dialysis. But for the drugs like vivaluridine and ergotopran, no known reversal agent is available. The only advantage with this drug is they have a shorter half-life. What about rivaroxaban, apixaban, edoxaban, and betrixaban? You can give oral activated charcoal. Drugs like adixanate alpha are being available at the moment in few centers. If not, then 4-factor PCCs. And the most important point regarding rivaroxaban, which is commonly used now, is it cannot be removed with dialysis. We had a trauma patient in case 1 who had sustained liver injury. So trauma itself can make the patient either hypercoagulable or hypocoagulable. There may be a release of tissue thromboplastin, or there may be platelet dysfunction, fibrinolysis, consumption coagulopathy, hemorrhage that is related to trauma, and patient can develop acidosis and patient can develop hypothermia. So patients with trauma, they might the DIC or may have coexisting DIC, which might not be evident till surgery starts. Why I'm saying this particularly, this is very important clinical point. This is because whenever we get a patient, we do lab investigation as soon as the patient arrives in the emergency department. But once we find that the lab coagulation or the other lab investigations are having some abnormalities, we take some time in optimizing the patient. We may not repeat the platelet count or prothrombin type or maybe the EPTT just before taking the patient inside the operation theater. And it has been mentioned already that there might be ongoing coagulopathy, especially in patients who have sustained trauma. So the incidence of, again, the patients who have sustained traumatic brain injury, the incidence of related coagulopathy has been found to be around 25 to 30% of the cases on admission. And as I mentioned earlier, the most important factor that it doubles within 72 hours post-trauma. And this trauma-related coagulopathy is to be detected early and by adequate hemostatic monitoring, as it can avoid secondary brain injury, especially if the patient has sustained traumatic brain injury. Recently, an article has been published about the use of tranexamic acid in the year 2019, and this study has showed that tranexamic acid is safe in patients who have sustained traumatic brain injury, and it should be given within 3 hours of injury, and has been found to reduce the head injury related death. So there is a recommendation that patients should be treated as early as possible after the injury. This is the most important slide of the presentation which we need to follow if the patient has to undergo emergency surgery. As I mentioned, coagulopathy may already be present in trauma and can worsen rapidly. So we need to have FFPs, we need to have platelets, and we need to have pancreatic cells. And they should be given in the ratio of 1:1:1. Along with that, you can give tranexamic acid, a loading followed by infusion, and vitamin K should be there, always given. And this is nothing but it is called as hemostatic resuscitation. So any patients who has to undergo emergency surgical intervention, this hemostatic resuscitation has to be followed in every patient with deranged coagulation profile coming for emergency surgical intervention. So let's go back to our case 1. A 21-year-old guy sustained liver injury, resuscitated with the coagulation profile is abnormal, and the surgical lead team now wants to explore the patient as early as possible to stop the ongoing hemorrhage. As I mentioned in the previous slide, you need to optimize the patient and make him fit as early as possible with hemostatic resuscitation, because you cannot wait for surgical intervention. At the same time, you have to continue the hemostatic resuscitation intraoperatively for so that the DIC itself should not kill the patient, and therefore you need to be very active in managing the hemostasis in this patient. Do the surgical intervention as early as possible, but at the same time, be worried about trauma-related coagulopathy and be alert and continue your hemostatic resuscitation, not only intraoperatively, but also post-operatively, so that patient should not need again a re-exploration for the same reason, that is again a hemoperitoneum in the abdomen. The second case, the surgical teams wants to explore the patient, thinking that patient may be in septic shock, having a perforation, but he needs to be explored as early as possible. Though they are emergencies, but you get some time to optimize the patient. So treat the cause of sepsis. First find out the cause and then treat the cause of sepsis. Starting on higher antibiotics, maintain hemodynamics, optimize respiration, maintain good ventilation, give organ support. These patients need coagulation profile, so hemostatic resuscitation is needed, and optimize the patient for surgical intervention as early as possible because patient is already in septic shock and maybe on the verge of multi-organ failure. So better to explore the cause, explore the reason for sepsis and treat the cause. And that is the most important thing in a patient who has deranged coagulation profile because of sepsis. The third is a case of this spinal cord hematoma, which needs surgical intervention because to save the patient's life. As the patient had sustained acute MI, you need to have a cardiology consult, optimize the patient, use advanced cardiac monitoring during surgical intervention, maintain the hemostatic balance, try to get INR less than 1.5 before surgical intervention, or if not possible, if there is if the surgeons are really in hurry to operate the patient, then continue your hemostatic resuscitation intraoperatively. Explain the risk of bleeding to the surgeon, to the patient, and as well as to the relatives. Continue reversal of anticoagulants intraoperatively. This can be done in a case 3 patient, and a case 4 patient who is thrombolized and who comes with neurosurgical emergency and needs emergency craniotomy. He needs good neurocritical care. He needs fresh frozen plasmas, vitamin K, hemostatic resuscitation. He should be operated as early as possible. And this patient came to our setup, was operated. He received 8 units of fresh frozen plasma. We brought down his INR less than 1.5. We gave vitamin K. We arranged for packed red blood cells. Operated him within 8 hours after coming to our setup, and he showed good recovery, and he was discharged after 3 days, after 3 months, but in a stable condition. So the take-home message for elective surgery, anticoagulant reversal, you get time, so it can be planned. But emergency surgeries are challenging. Depending upon the urgency of surgical procedure, anti-reversal coagulation can be planned, and you need to have a multi-pronged approach with consultation of all the specialties, the hematologist, surgeon, neurosurgeon, intensivist, anesthesiologist, and that is very important and very crucial. And in this patient, the most important point is you need to continue the hemostatic resuscitation intraoperatively because these patients need urgent surgical intervention. Thank you so much. Thank you for inviting me on prestigious dais, and I would like to have many questions because this topic is really interesting, and so many times we need to manage these patients clinically in an emergency as well as electively also. And with Dr. Thomas Koshi sir chairing the session, I'm really looking forward for an active discussion. Thank you so much.
So thank you, Dr. Manisha, for that brilliant lecture with great practical illustrations. I hope that you have managed these cases in your day-to-day practice. So now we'll open the question answer session. So before going to question answer session, I just have one question to you at the case number 2 with a platelet count of 40, less than 50,000. Did you give a platelet transfusion?
Yes. Okay. Sir, as I mentioned on the slides, the hemostatic resuscitation includes fresh frozen plasma, platelet, and blood, packed red cells in the concentration, in the ratio of 1:1:1, and that has been the recommendation now by the recent guidelines that give it in the ratio of 1:1:1. If platelets are not available, because so many times the platelets are not available at all the centers so easily, then you can give more fresh frozen plasmas. But then you have to get the platelet count above 50,000. You need to optimize this patient with early hemostatic resuscitation.
So the transfusion threshold is 1 lakh or 50,000 in your center?
Sir, for exploratory laparotomy, 80,000 should be the transfusion threshold for surgical intervention. If it is an intracranial surgery, of course, 1 lakh is needed for intracranial. For the platelet threshold should be at least 1 lakh.
At least 1 lakh. Okay. So now invite all the 3 speakers. Well, I am going to the chat box right now. Let me see some questions are there or not. People have given their TC numbers, the medical council numbers. Presentation is practice.
Chairperson sir, Dr. Koshi sir.
Yeah.
See, the questions were,
Yeah,
I have seen a couple of questions. One, if the patient is receiving fondaparinux, what is the anesthetic management in elective and emergency surgery? And another question is, emergency interstitial obstruction, coronary stented patient comes up in midnight in periphery. What are the precautions to be taken? Patient is on clopidogrel and no time to stop. That is a question. And protein S deficiency posted for LSCS, anesthesia management. These are all the questions I have seen.
Fondaparinux, basically, maybe the indication is thromboprophylaxis only. So it must be a low dose. So 36 hours is what is recommended. We generally do not give high doses of fondaparinux, but for any reason, if the patient is on a high dose, then it is absolutely contraindicated to touch the spinal cord for whatever reason, I suppose. And Dr. Koshi sir would like to enlighten us more.
Madam, because fondaparinux, the dose is same for everyone. It is not weight based or anything. So if there is no antidote also, so when emergency surgery,
and it is a longer acting drug as well.
How to manage emergency surgery?
See, fondaparinux, I don't manage such cases because they are practically we get heparin. But if we look at the latest fondaparinux, I'm just looking at the evidence in Miller. It is not mentioned there.
Actually, sir, it is a great clinical challenge if you get a patient with Fonda heparin for surgical intervention and that to emergency surgical intervention.
Because even the madam slide does not mention about fondaparinux, Dr. Manisha madam.
Yeah.
You have omitted that practically because this question is from Dr. Meenakshi Sundaram.
So the guideline is not given, I think, fondaparinux.
No, the guidelines have classified it as a low dose and high dose, like I mentioned. And for low dose, we would stop for 36 hours if it is an elective surgery, which may not be possible if the patient comes for emergency surgery. So I think for emergency surgery, the management would be same like any other anticoagulant if the patient is upon, like for example, warfarin. I don't think it would differ much, especially when an antidote is not available, like Madam mentioned for DOACs. So I think we will have to take into consideration all those factors. It is not reversed by any agent. So
yeah,
we need to continue. We need to continue the hemostatic resuscitation throughout the perioperative period, and that is what Poonam has said correctly. That we just cannot stop for emergency surgery. We cannot do anything. So we just follow the hemostatic resuscitation throughout, so that the emergency surgery can be dealt very well. But at the same time, if you need to explain the risk to the surgeon as well as to the patient and his relatives, and general anesthesia will be the choice of anesthesia.
Okay, so regarding neuraxial blockade, I think the longest stoppage is required for ticlopidine, that is on 14 days, and followed by clopidogrel 7 days, then warfarin 5 days. All others are on the 1 day to 3 days period. And regarding the prosthetic valve, in Poonam's lecture, if it's a bioprosthetic valve, there is no warfarin. See, only the first 4 to 6 weeks they give the warfarin. After that, it is aspirin or aspirin and clopidogrel only. So we have, and regarding mechanical valves, prosthetic valve, both bileaflet as well as monoleaflet valve is same only. You have to give that warfarin lifelong. I think only the latest bileaflet valve, I think the name is Onyx valve, which can be put on a dual antiplatelet. All other mechanical valves is on a lifelong warfarin. Now, one question to all of you is, for our routine surgery, do we need to do any coagulation profile, elective surgeries, assessment, like bleeding time, fibrinolin assessment or any other time we need to see for a routine surgery?
Yes,
Generally,
sir, I would.
yes,
Yeah.
ma'am.
Generally what we follow, like what we follow in our setup or in our practice, because I work in a neurosurgical setup. So we do a PT, the prothrombin time, and of course CBC is done, so you see the platelet count. We usually do not do APTT, but we do PT-INR. If there is some doubt or there is some history, or if there is some low platelet count, or if there is something abnormal, then we usually go ahead with APTT. Otherwise, routinely we do PT-INR for every patient who is coming to us for surgical intervention for elective case.
Platelet count is routine, but I don't think the recommendation for routine PT every patient. I just
Yes, sir.
read the guidelines. Unless there is a
Yeah.
history suggestive of some disease, and that is the current recommendation. And Meenakshi, you can also give your opinion of routine PT in your practice.
Yeah, because see, most of the times we face do or die situation only. So see, even Dr. Prema Rajagopalan question is intestinal obstruction, coronary stented patient coming with the anticoagulant in a periphery means, see, the patient is undergoing stent replacement in a corporate setup and he is on 2 or 3 anticoagulants, but landing for emergency surgery in a periphery setup where there is no component blood transfusion. That is the real catch. That is the reason why they are asking. So we have to address their grievances. So if an emergency patient lands up in a periphery, that routinely happens, you cannot refer the patient also. So we have to throw some light on that. Anyway, every situation is tricky. We can guide them what best we can do in that particular setup. We cannot say every time we should have an ideal setup. That is not possible in an emergency setup. So even now, another question is there, what is the role of TEG?
We will come to that question later on. But patient with coronary stent for any non-cardiac surgery, the ideal recommendation is they should be done in a setup where you can have a immediate coronary intervention. Because you lose a patient if you listen. You get away with 95% of the patient or 99% of the patient. But the recommendation, if you have a stent, there should be a cardiology department when you go for any surgery, cesarean section or anything. I don't recommend to be done in a peripheral setup, because even the court will hold you responsible, because court has held many people anesthesia responsible without a ventilator. Why did you give anesthesia? So we have come to that.
We would probably need invasive monitoring also in this patient. So no point in doing in a small center.
Yeah, so that is the answer. And regarding TEG, that is our last question. Is it routinely required, or what is the indication unless the patient is bleeding?
We are not doing routinely TEG in patients on anticoagulation. Specifically for this anesthesia management, I don't think anywhere they are doing a TEG as a routine investigation.
Probably for transplant surgeries, they may be doing operatively. But
if the patient is posted for liver transplant, I think only in a liver transplant zone this TEG is performed routinely. And I don't think for anticoagulation it is not done. And I think it will not convey any meaning, because we know already what is the drug the patient is getting. We know already what is a drug. So it may not be of much use to doing TEG.
See, preoperative TEG is not recommended as per the recommendation or per the guidelines. But in a bleeding patient, especially cyanotic patient in a cardiac surgery setup, TEG is useful. In a liver transplant center or in any transplant, a lot of bleeding is there. And those centers, it is recommended, and it has shown routine use of TEG or ROTAM has shown to decrease the transfusion requirement, or it will tell you what exactly is the component therapy which is required. But preoperative TEG is not recommended as per my knowledge as a preoperative screening.
Yeah, other than Yeah, other
Yeah,
than transplant, probably massive obstetric hemorrhage is one place where one would like to do TEG, and that would guide the transfusion that is exactly required, whether it is platelets or recombinant factor, whatever, that can be guided through the TEG value. So that is one place other than transplant where one may use TEG. Preoperatively, there is no prerequisite that one should do TEG.
But even in obstetric hemorrhage, we will not wait for any investigation. Even this coagulation profile,
Yeah,
it is
that's
the
true.
high emergency period, so we cannot wait for TEG and all. As Madam pointed out, again we have to transfuse 1:1. So I don't think even in obstetric hemorrhage it may be theoretically possible, but it is very difficult to wait for TEG and all. Very difficult.
Meenakshi, let me tell you, the modern tech
Point
machines,
of care. So,
the modern
Sir, the
rotor
first thing-
machines. Yeah, okay, tell.
Sir, I just wanted to mention, sir, I just wanted to convey that many of the labs at in the various setups are not having thromboelastography or rotational thromboelastometry. Definitely, it will put a light on the exact etiology or the exact factor. The pattern will tell us about the exact etiology of the DIC or the deranged coagulation profile. But at the same time, sir, as Dr. Meenakshi Sundaram said correctly, for cardiac surgeries, that might be helpful. Or in a patient who has ongoing hemorrhages, that might be helpful, which will throw some light on what specific factors has to be given or transfused to that patient. But for routine emergency surgical interventions like a massive obstetric hemorrhage or a patient with a major trauma who comes for emergency laterotomy, will it be helpful, sir? Will it be helpful?
Yeah, it is because the modern machines give the report within 10 to 15 minutes.
Yes.
Yeah, it is
So the
point of
report is
care. So you
available,
immediately get the reports and it can guide. It is point of care. Immediately you put in and you get the report and it can guide as to what exactly the patient needs. What components?
That is the blood bags.
Yeah.
So you're talking about the previous tech which used to take 45 minutes. The modern machine. That result will come from this is usually now the tech is or rotom is done by the Department of Transfusion Medicine, and they give blood bag as well as PT and the rotom report together. So I mean, we don't have to worry. The modern machines are good.
Sir, chairperson, chairperson, so we can give a take-home message to everyone. In a peripheral setup, what we mean a peripheral setup is where the facility is not available. Even in an emergency surgery, it is not better to take up the patient in that setup. Is it right? Even if it is an emergency surgery.
Emergency, sir.
Because Madam has asked, sir, the question was, intestinal obstruction patient with coronary stent landing up in a...
No, never take up.
Never take up. That is right. That is a take home message. Then repeatedly one question is asked, sir. Chairperson, sir, repeatedly one question is asked. If the platelet count is less than 50,000, can we proceed under central neuraxis block for LSCS?
No. Again, no.
So any of the panelists wants to take up less than 50,000.
First of all, let us apologize that we did not include anything about obstetric because it would be a different ball game altogether. We probably would need to have a theme just based on anticoagulants and obstetric anesthesia. So absolutely no, if it is less than 50,000, even by the Hematologist Association, they say if it is between 50 and 75,000, an individual approach is required. And above 75,000 of platelets, you can safely give spinal anesthesia. That is for cesarean section.
75,000 is the recommended value, isn't it?
Yeah. Yeah, few guidelines have mentioned 75, few guidelines have mentioned 80,000.
Right.
And regional blocks for platelet count, anything? Regional blocks. Let us say the brachial plexus block.
No.
Ultrasound guided blocks can be given, isn't it?
Yeah, the ESRA recommendations say so that if you are giving ultrasound guided by an expert anesthetist, the person using the ultrasound should not be naive in using the ultrasound for the first time. So expert anesthetist giving the block with ultrasound, so it may be given.
But again, the count has to be more than 50,000.
50,000, yes.
Okay.
Yeah.
So any other questions in the chat box?
Sir, there is an important comment from one of the attendees. How many small hospitals have facility of 1:1:1 component transfusion in small town? And this is really important. And I would like to mention here that in my city, Solapur is a 3-tier city with advanced medical hospitals. But here also, many of the hospitals are not having their own blood banks, and to get platelets, it becomes really difficult. So for a small town, again, the transfusion hemostatic resuscitation with 1:1:1 is really going to be a difficult situation. What is available easily is vitamin K and fresh frozen plasma, and of course packed red cells. And I think even whether it is a small town or a big setup, these things are easily available. Yes, you do get platelets, but then to transfer them in the ratio of 1:1:1, which is recommended, it becomes difficult, definitely in a small town.
Yeah, you're right. And our blood bank recommends this technique, this ratio for massive blood transfusion. So we just have to tell the blood bank that we have a massive bleeding, then they send products like this.
Chairperson, sir, another question is there whether there is any contraindication for CVP intra-arterial monitoring in a patient with anticoagulants.
Contraindications for yeah. Anybody wants to take?
Sir, I think again we have to check the coagulation profile. For CVP, there is a recommendation that the platelet count should be at least 20,000. For putting intra-arterial line, I really do not know, sir. You might give an expert opinion, Thomas, sir. But for CVP, there is a recommendation that ultrasound-guided CVP cannulation can be done with a platelet count of 20,000.
Yeah, see, nowadays in our hospital, 99% of the central lines are put under ultrasound. We don't recommend putting blindly. So it's a very precise. So if we can put a peripheral vein under vision, just similarly, the ultrasound converts a central vein into a peripheral vein. They are rendering directly, so absolutely no risk. And the arterial line also is the peripheral artery. It is not an issue, but that is mandated by the surgery of the patient going to undergo. So major surgery, if it is required, we have to put. And again, we practice ultrasound guided both radial artery as well as femoral artery punches. So we don't miss, we don't search. So it is it's like we convert the central vein and artery into like a peripheral vein only under ultrasound. So it's not at all a risky procedure. But the guideline says 20,000 is correct. But the procedure wants, you can obviously take under ultrasound. But the question is, the person should be experienced in ultrasound. I've done hundreds. Otherwise, don't try it on a patient who is having a low platelet count ultrasound for first time.
Even a single count should not be considered. It should be a trend of values. You are monitoring the patient. Just do not rely upon a single count of 75,000. It may be 75,000 yesterday. It could be just 40,000 today. So the fall in platelets and the rate of fall is also equally important when we decide upon doing invasive monitoring or a CNV.
Okay. Any other question?
There was a question on protein C deficiency earlier. So basically the protein C, protein S, they are procoagulants, and when the deficiency occurs, generally commonly seen in obstetric patients because of the spontaneous abortions. And when they do conceive, the patients are put up on heparin or low dose ecosprin, which is continued till full term. So nothing different. You just have to manage the time of interruption of the heparin and ecosprin, and then you can give a spinal anesthesia according to the guidelines. Nothing different as such.
Okay, thank you.
There was one question on desmopressin, I suppose, Dr. Bharti.
CDAVP.
Yeah.
Yeah.
What is that question? Any role for DDAVP?
Yes, any role for DDAVP? Desmopressin. Of course, it must be having a role because, Poonam, you want to add something? Because I don't have any experience of using desmopressin. I use desmopressin for the nasal spray, especially for
No,
military patients.
I do not know
But
exactly what.
Desmopressin may be having role, but how will have to, even I will have to read about it.
Koshi sir, maybe Koshi sir.
Desmopressin, desmopressin, now often I can't answer. Desmopressin. May I have to look
Desmopressin,
at.
sir, for trauma coagulopathy, I read that there is a role of desmopressin, but I'll have to still find out. I think I will get back with the reading for trauma, for especially for DIC.
DAC it
There
is
a role of
used, but
desmo.
for a specific indication for desmopressin.
Yeah, there is an indication for desmopressin for DIC, especially trauma-related DIC.
DAC. But the exact indication, you have to look.
In von Willebrand disease, probably, or hemophilias, but I do not know in hemorrhage, how will one diagnose that the patient is having von Willebrand unless one gets the test done. Routinely, I don't think it is advocated unless you know that the patient is diagnosed to have von Willebrand disease. Probably that is the drug of choice in those patients.
Okay, right. No, that is not a routinely used one. So, limited experience. I don't have any experience, but we have to look at the guidelines. Okay, any other question?
No, I don't.
Could I just ask a question here? I'm Dr. Nalini.
Yes, madam.
Nalini Kutika from ISO.
Yes.
Yes, it was an excellent presentation from all the speakers. And I just wanted to ask one small question. That is, now the tendency is that, we use spinal needles, which are about 27 and, 27 is in vogue. So normally the tendency is that, even if a patient comes for cesarean and she has a deranged, coagulation, sometimes the tendency is that, okay, just with a 27 needle, we'll give a quick spinal. So what's your comment on that, Manisha and Poonam?
With patients with deranged coagulation profile, with low platelet, raised INR, and then spinal with small gauge needle. That's what you want to ask?
Yes, yes. Manisha,
I would not
that's
go,
right.
I would not go. I would not go because though the needle bore is small, but there is a risk. Since the patient has deranged coagulation profile, there is a risk of it. Why to take the risk? Because this is not justified anywhere in the court of law. If the patient develops spinal hematoma, spinal cord hematoma, then it will not be. We cannot explain the use of spinal anesthesia in patients with low platelet.
Right. Thank you so
So
much.
we need to first answer why is really GA risky in those patients for cesarean section. Is GA risky or not? The question would be answered altogether in a different manner if the same patient is with severe PIH and with probably a 65,000 platelets with a BP of 200 by 100. Probably in those cases, I might take the risk of giving a single shot spinal, fearing intracranial bleed that may occur after giving general anesthesia, the vasopressor response. So the answer would be completely different. The question that you are posing is in an otherwise normal patient, parturient who has come for cesarean section and with a low platelet count, I don't think that I will give spinal in this patient because it is not justified.
Right.
So I just found out the desmopressin. The low platelet count less than 50,000 and patients on antiplatelet therapy. You can give platelet transfusion or desmopressin. One of them.
How desmopressin is given? How it is given orally? Because I know about intranasal sprays of desmopressin.
That I have to see desmopressin. So that is a recommendation given.
Dr.
Low
Ripan
platelet
Chaudhary has
count
commented. Yeah. There is a
and
comment
for
from
a
Dr.
patient on
Ripan.
antiplatelet therapy. There you can try DDV for desmopressin. Specific indication.
And another point that normally we forget is that whenever we are taking up these patients and it's an elderly patient, they say that INR has to decrease by the time we take the patient for surgery. But we need to remember that in elderly patients, they are associated with a slow rate of the INR coming down. So in that case, how do we handle the patients who are elderly and who have coagulation abnormalities?
So for elderly patients, there might be coexisting illnesses like associated liver or renal diseases, and that might be the reason. Patient may be having underlying sepsis, so that might be the reason for fall in INR, that the expected value should be less than 1.5, but patient is taking time. For emergency surgeries, we should now, if it is really a life-saving surgery, we will have to continue with surgical intervention, even if the INR is more than 1.5, and we need to continue our 1:1:1 formula, and that has to be done.
Okay, thank you, Manisha. Another point that I thought I will just share with the PGs is nasal intubations and NG tube insertions are to be avoided in these patients.
Yeah, sure.
That's just a point that I want.
That's a valid point.
Yeah,
absolutely.
This nasal intubation and in what cases is surgery specific indication? Otherwise, for a routine any surgery.
Now suppose
below neck and below there is no one. Oh yeah, tell me below neck and below.
Suppose we are doing any trauma which involves OMFS surgeries. In that case, so many times we have to put in the nasal tube.
Yes.
In those cases, we are in a dilemma because they want it because the space is compromised. But then again, we are not justified in putting a nasal tube in these patients. So probably you could have to go ahead with a submental or something like that. But avoid a nasal.
Madam, these emergency facial traumas are not an emergency. They are not life-saving surgeries. If patient has deranged coagulation profile, you need to correct this deranged coagulation profile, get back to the safer levels of platelets for this kind of major surgical intervention, because managing maxillofacial trauma with surgical intervention is a prolonged surgical intervention, and you cannot operate them on an emergency basis with deranged coagulation profile. So you need to correct the deranged coagulation profile. And even for submental intubation, madam, the first thing you have to intubate that patient, and if the surgeon, the plastic surgeon, if demands for a nasal intubation, then you have, because for submental intubation also you need to have an endotracheal tube inside the oral cavity. So if the patient's mouth is not opening because of maxilla as well as mandible fracture, then how can we proceed with the surgical intervention, especially in a patient with deranged coagulation profile? These are not surgical emergencies. We need to wait for the platelets to come to normal.
Madam,
so many times.
Madam, she exercises a word of caution that in deranged coagulation profile, hesitate to attempt a nasotracheal intubation. Whether it is submental or tracheostomy, whatever it is, anyway, it is a man on the spot is the best judge. She wants, if there is a deranged coagulation profile, instead of saying avoid nasotracheal intubation, she wants to say hesitate. Think twice before attempting nasotracheal intubation. That is right. That is right.
Also, the act of putting in an NG tube also is a little risky.
Sir, even for lumbar puncture
also. You have to avoid or cautiously use intramuscular injections also. So all those precautionary measures have to be taken in patients who have deranged coag profile.
True.
So even I would like to mention, Nalini madam, that if a patient has if one has to go ahead with lumbar puncture in a patient with deranged coagulation profile, one has to be very careful again. And the platelet count that has been mentioned in the guidelines is around 20,000 for lumbar puncture. So again, when I read about those guidelines, again, there was a problem. There was a question in my mind, as the question you asked initially, For the first
Yes.
case, that can we go ahead with 27 gauge needle? Then for
Yes.
lumbar puncture, that we have again means when I was talking to you right now, that question came into my mind, that if for lumbar puncture, if there is a guideline is mentioning a platelet count of 20,000, a therapeutic lumbar puncture, maybe for lab investigations, then why not for spinal surgeries? They are mentioning about the lumbar the platelet count more than 50,000. So that again we'll have to find out.
Madam, till we are getting caught, we are not thieves. So if you are getting stuck up with the spinal hematoma, then you will be in soup. That is the only thing. See, we can say you whatever you can do, you can do. But if you are getting stuck, definitely it is a problem. So now we were practicing safe medicine, defensive medicine. So we have to be very careful, especially in that small area, that lumbar puncture. We have to be very careful. Careful. That's what we want to say. That we have to be very careful. Then if destiny decides again, this 20,000, 30,000, 50,000 platelets, quantity is not a matter. Quality is also a matter, which we cannot decide. We don't know what will happen. See, just by number, we are performing a prick. So what we want to convey, we have to be very cautious when there is a problem.
True, sir. Very true.
I have
If there is any questions, if there is no more questions.
What about tranexamic acid? Everybody use it? Tranexamic acid?
Yes.
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 It is the most useful.
Yes.
Sir, as a cardiac person, you will be using it often.
We are using it very
All
frequently,
cases.
We
sir.
use
All
it very
cases.
often in spine surgeries, major surgeries where we are expecting blood loss. We do use.
Many people are using it even for elective surgeries. As a pre-medication, they are using tranexamic acid.
Yeah. See,
Sir, our
we
surgeons
use it.
feel happy that we are using our surgeons before taking an incision. They will ask, "Have you given tranexamic acid?"
Yeah, we are
They are
routinely
paranoid
using.
with tranexamic acid.
And whether the patient bleeds or not, whether the patient has coronary artery disease or not, everything, undergoing CABG surgery, there are certain, cautions, exercise or mentioned earlier that can produce coronary artery thrombus. Those are all gone. Now, guidelines says it is recommended.
Yeah.
So every case we are using, whether cyanotic or acyanotic, clearly indicated. The second is there a role for a platelet function analysis?
Not possible, no?
Platelet function.
Not possible qualitatively. That's
Except
what
thromboelastogram or rotem, other tests like platelet aggregometry or a P of 100, those are not routinely recommended. So guidelines do not recommend routine use of it.
No.
Shall we wind up, sir, if there is no more questions?
Yeah. So we have
Yes, sir.
5 more minutes or 7 more minutes to 8 o'clock. We have a wonderful
Yeah.
session.
So
thank,
I have to personally thank the faculty for sticking to their time schedule. They are perfect. So a lot of time was available for discussion. All the three perfect. 70 minutes was given to them. They have finished it in 67 minutes. And I thank Dr. Koshi sir because he was acting as a Google. Immediately when there is a clarity is required, he was walking Google. Immediately he refers and answers. And now we hand over the session to the president, Dr. Suresh Kumar.
Thank you, ALM sir. A very good, fantastic meeting we have witnessed. After Dr. Daya launched the cascade, Dr. Poonam madam and Dr. Manisha madam gave a wonderful lecture. And this is definitely an eye-opener for every anesthesiologist who have participated in the proceedings. Definitely, they will have a review and refresh of the knowledge, and it have very good practical implications. And the lecture was very well coordinated and compiled, gave practical contributions by our chairperson, Dr. Koshi sir. Thank you, everybody, once again. It is thanks giving time. I our treasurer, Dr. David, to post the vote of thanks. Thank you.
Before that, President sir, this session had 109 audience, and we are happy. Even at the time of discussion, there were 102 participants were there. This is the second best. Our best number was 118 for pacemaker webinar, and this is the second one. You have exceeded by one. Previously, 108 was the second best, and now we congratulate this team to have the attendance of 109. Thank you. Over to Dr. David.
Thanks.
Good evening, sir. Good evening to all. On behalf of IAC Pudukkottai, first of all, I would like to thank Academic Chairman Dr. A.L.M. sir for selecting wonderful topics, very useful to PGs and practicing anesthesiologists. I also thank today chairperson Dr. Thomas Kosi, Professor of Cardiac Anesthesia, Sri Chitradhanal Institute, Trivandrum, for sharing his experiences. And I also extend my thanks to Dr. Manisha ma'am and Dr. Poonam ma'am and Dr. Dayanandan for very useful and practical academic session. I also thank postgraduate and other faculties for sponsor Actuarial Law and A1 Logics for a very successful event. Thank you, sir.
Thank you so much. Thank you. Thank you so much. Thank you, sir. Thank you so much.
Good night.
Good night.
Thank you, sir. Thank you.
Thank you. Shilpa can close.